And in next 10 minutes, I'm going to trying to convince you that you should be managing diabetes in patients with MESELT and how easily you can do it. Let's see how successful I am. So since I'm talking about a revolution, I thought it's actually might be good to start with prerequisites of a successful revolution. Anybody who's aware of communist literature would have read this sometime in their life. So for a revolution, first thing you need is the masses actually need this. Read masses as patients here. Do the patients actually need hepatologists to take the decisions about the antidiabetic medications or not? The second prerequisite is ruling class split, which is evidence. So Jasjeet and me are debating whether I should be using it or not. So that's a ruling class split here. There should be a powerful unifying motivation. What's the unifying motivation here? Doctors and patients working together for the patient's benefit. So would that help or not? I'll talk about that subsequently. And fourthly, you need a permissive world context. In our situation, it would mean who can prescribe these medications. So I guess point number 2 and point number 4 are settled. We have a split, and we being internists before gastroenterologists are allowed to prescribe these medications. So I'll detail about first and third point. So let's talk about need first. Dr. Siddiqui has talked about NFL prevalence across the world. In India, almost half the people who live in urban cities have NAFLD or MASLD. 25% of rural population in India has MASLD. Almost 80% have metabolic syndrome. So that's the starting point. Let's flip the coin around. Let's see what happens if a patient already has diabetes. So there is literature in India which shows almost 60% of patients with diabetes have a fatty liver disease. But what is interesting is, of these 60%, more than half of them actually have what you call steatohepatitis with or without fibrosis. So if you take the count as 60% and half of them have NASH, that means 30% of all diabetics need liver-specific therapy. Who's going to do that? You. But more importantly, why do we need to manage diabetes is because the aim of managing metabolic syndrome along with liver-specific therapy is to correctly manage metabolic syndrome. Now, what decides what medications to give, what doses to use? It is primarily the liver disease. If you have a significant liver disease, it has a huge implication on the medication you are using. I'll try to talk about this subsequently later, but please remember your choice of anti-diabetic medications, not oral hypoglycemic drugs. Anti-diabetic medication depends on what is the extent of liver disease in this patient. So it may be worthwhile one person managing both. I'll talk about this. Person who understands liver disease better may be better equipped to manage metabolic syndrome also. The important question is, are we there yet? Is it feasible for us hepatologists, gastroenterologists, who've been trained to manage liver disease to adjust diabetes medications or not? I'll run you through the conventional management of diabetes. We are all aware of these drugs. We have bigonides, we have secretagogues, we have thiazolidinediones, insulin, and the newer age anti-diabetic drugs are the ones which are coming into contention, which have a specific role in management of MESELT. Dr. Siddiqui told you thiazolidinediones are not very useful or not very preferred. They may be useful, but they are not the preferred drugs because of the reasons he already told you. The drugs which we need to avoid when we are treating MESELT, if at all possible, are secretagogues. So drugs like gliclazide, drugs which have high half-life, long half-life, they are to be avoided. I'll discuss this subsequently. But what is the focus today is GLP-1 agonists and SGLT2 inhibitors. And please remember, these are not just anti-diabetes medications. These are medications which improve the overall metabolic health of the patient. More importantly, these are medications which in addition to helping the diabetes, they cause weight loss. They cause further metabolic improvement in renal function and cardiac dysfunction. Let's talk about SGLT2 inhibitors first. We are aware about the data of improvement of liver health in patients who are on SGLT2 inhibitors. This is one meta-analysis which I'll talk about. This is 10 randomized controlled trials. All NASH patients with diabetes who were treated with SGLT2 inhibitors. Overall, the meta-analysis showed that there's an improvement in AST-ALT. There is an improvement in FIB-4 scores. Documented improvement in fat in the liver as measured by MR-PDFF, and overall fat composition in the body was improved. We don't have biopsy data, Dr. Siddiqui rightly pointed that out, but we have ancillary data to say that liver health does improve. But what is more important? In addition to improving liver health, you are improving overall health of these patients. Now, this is published last year. This talks about cardiac benefits of SGLT2 inhibitors. Mind you, these are not patients who have diabetes only. These are patients who have cardiac disease with or without diabetes. 11 randomized controlled trials, 34,000 patients. They categorized their patients into 4 categories. They talked about major adverse cardiac events in patients who already had MI, patients who had CAD but without MI, patients who had angina, and even patients who did not have coronary artery disease. These are patients who either had diabetes or did not have diabetes, right? So even non-diabetics were given these medications, and the forest plots tells you that the overall cardiac events are much lower in the patients who are on SGLT2 inhibitors. So you are helping liver disease, you are helping diabetes, you are helping cardiac side effects. Renal dysfunction data, Dr. Siddiqui has already told you. So it's high point that you start adopting these medications in your practice. And is it really difficult? What are we scared of? We are scared of adverse events of these medications. The primary adverse event used to be described as hypoglycemia. Now, mind you, SGLT2 inhibitors hardly have hypoglycemia unless you are using these medications along with OHAs. Right? OHAs we anyway don't like to use in patients who have advanced liver disease. So hypoglycemia risk is over-exaggerated. Dosage is simple, once a day dosing for these medications. You have evidence that they work in diabetics and non-diabetics. You have ongoing trials that patients with advanced liver disease who do not have diabetes, the drugs may help. The data will come in a year or 2. So time to adopt these medications, that's what I would say. The second class of drugs are GLP-1 agonists. Again, semaglutide data, I don't need to tell you, we've been talking about this data for last 2 years. The NEJM article we are all aware of, there is a phase 3 trial going on. It was originally licensed as an anti-diabetic drug, but now we have data that it works in obesity. It works in metabolic dysfunction-associated liver disease, in patients who have diabetes, in patients who do not have diabetes. So even in a non-diabetic patient, you are happy treating them if they have a fatty liver disease or obesity. Then what is the problem in managing their diabetes with these SGLT1 agonists? Again, once a day dosaging, simple to use, no side effects. You have data that these drugs are safe in patients who have cirrhosis. So you have MASLD with fibrosis, with cirrhosis, these drugs are safe. They don't cause hypoglycemia. You don't have to worry about major side effects. They help you protect the liver. They help you protect the cardiac status. They help you protect the renal functions. Why not use them? So I make a strong point in using these medications, getting used to. So generally what happens, something we have not done, we have a fear of starting doing. I want to get you to get rid of that fear and start using these medications. And I think Jasjeet will assure you that these medications have very, very few side effects. Importantly, we are always scared that these medications are metabolized by liver. Now, I'll tell you 2 things about each one of these drugs. The SGLT2 inhibitors are metabolized in liver, but they are not hepatotoxic. The dosage does not depend on whether the patient is child status A or B or C. They are safely used in child A and child B. Child C data we don't have. We might have data tomorrow and we might like to use it. GLP-1 agonists are not even metabolized in liver. They are not metabolized in kidney. They don't have a specific organ of metabolism. The major route of elimination is in the body itself, not a specific organ. You don't require dose adjustment, whether the patient is cirrhotic, fibrotic, or a fatty liver disease. And you already have data that they're safe in cirrhotics. Why not use them? I urge you guys to start using these medications for more and more effects. Jasjeet is here. Do you want to make a point now, Jasjeet? Okay. The final part of my presentation. Is there any advantage if we start using it? Remember, the advantage is for masses. Advantage is not for doctors. There are 2 major advantages if you start prescribing in the patients who are eligible, who are MASLD and diabetes. The first advantage is you are integrating MASLD and metabolic syndrome, which the definition which we have been looking at for last 2 hours proposes. Metabolic syndrome and MASLD should be integrated. The drugs you use for management of diabetes, the dosage you use depends on the stage of liver disease. I'll just give you one example. Talk about secretagogues. Talk about sulfonylureas and glinides. These are go-to drugs in patients who have diabetes, but they are all metabolized in liver. They are all albumin bound. The moment you have advanced liver dysfunction, there is decreased metabolism. The mean concentrations achieved of these medication in blood are higher. The elimination is slower. The half-life is prolonged. So a drug like gliclazide, which has 12 to 24 hours of half-life, gets prolonged to 36 to 48 hours. You have to decrease the dosage. You have to actually decrease the frequency also. Glimepiride has 8 hours of half-life. In a patient who has diabetes, it is 24 hours. So you have to be very careful in using these medications. Similarly, your statins. Similarly, any other medication you talk about in management of diabetes and metabolic syndrome. The same thing applies for thiazolidinediones. If you have advanced liver dysfunction, you can't use them. So who is better equipped to manage these medications in patients who have diabetes and liver disease? I think it is us. Second, and the most important reason why you should be advising, it causes lesser cost to the patient. So they don't have to go to Jasjeet, pay his exorbitant endocrinology fee, don't get investigated, and you manage on their behalf. So my dear friends, I propose this motion. It is time for hepatologists to prescribe and monitor anti-diabetic therapy in patients who have MASLD. The only disclaimer is the intention is to help, not to replace. Thank you for your patient listening.